So this is the cardiac review part 2. Um, this PowerPoint is not a PowerPoint that I made. It's someone else's. I just used it when I taught this course. So cardiac disorders. So we're going to talk about coronary artery disease and heart failure. So coronary heart disease or coronary artery disease, sometimes they're interchangeable. So when you're talking about coronary, you're talking about the heart itself. So when you're talking about coronary arteries, you're talking about just the arteries that are actually in the heart, not anywhere else in the body. So ischemic heart disease and arteriosclerotic heart disease, these are all talking about the heart vessels themselves. So when the arteries that supply blood and oxygen to the coronary arteries get blocked, it can be partial or completely blocked, and these are just other disease names. But coronary artery disease is the most common what you're going to hear. These are the different vessels in the arteries of the actual heart. So atherosclerosis versus arteriosclerosis. So atherosclerosis is when the artery gets narrowed because of fat or other buildup inside the wall of the artery. Arteriosclerosis is when the actual artery gets hard, so it doesn't have that elasticity, so it can't compensate for changing blood pressure. For this class, they're saying interchangeable terms. Both of them kind of cause the same effect. And an interesting thing when you actually look at a vessel that has atherosclerosis, that fat deposits in the vessels, the vessels actually expand. It's not just the space inside. The vessel actually enlarges itself. So this is the atherosclerosis, and they have these plaques, and these plaques can peel off. They can just totally occlude, and this is a problem from triglycerides and the low density because they're like less dense. They're kind of fluffier, thinner. So that's what really causes the problem. The denser ones are less of a problem. So the HDL is not, it's good cholesterol. It's not bad. It's not going to cause problems. And then this is just where the arteries get really, really firm. So coronary artery blocked by plaque and a clot. So this is a blood clot, and this is the plaque. The blood flow is stopped. Can have atherosclerosis, arteriosclerosis in any artery of the body. Can have it in extremities of the leg, but right now we are concentrating on the heart. So we're talking about coronary artery disease, so we're not going to be talking about peripheral vascular disease, which definitely an abnormal assessment here, wouldn't you say? Coronary artery disease. CAD is actually a spectrum of diseases. Angina, MI, myocardial infarction, heart attack. So it can be mild or severe. Coronary artery disease is a contributing factor for arrhythmias. I say dysarrhythmias because A means absence of, so I say dysarrhythmias instead of arrhythmias, but it's the same thing. So coronary artery disease is a risk factor for abnormal rhythms and heart failure. You know what rhythm this is? AFib. You can see the little fibrillations, so you can't see the P wave. Really no T wave or a U wave. definitely no P wave. It's just chaos in between. So one thing about AFib is the firing of the heart, the signal, it's just it's random, it's chaotic, it's not a rhythm. The heart doesn't, the ventricles and the atrium might contract at the same time, so it doesn't move blood through, and that's why people with AFib have high risk of developing clots anywhere in their body because that blood's not moving. Person may have the beginning coronary artery disease and not even be aware of it. Usually it's more advanced in the severe symptoms. And sometimes the first symptom is a heart attack. Causes and risk factors. Some can be modified and some are not modifiable. Older age, can't modify it. Race ethnicity, cannot modify it. Family history, genetics, cannot modify. Being overweight, you can modify. Dietary factors, can modify. Smoking, you can modify that. Alcohol, you can stop and modify that. Lack of exercise, modifiable. Sedentary lifestyle, definitely modifiable. Diabetes, can't necessarily modify diabetes, but you can control it or not control it. And stress. Stress is really hard, and people don't realize how much it affects your body, but it is modifiable, but it's very hard to reduce. Angina, from the Latin verb angere, meaning to choke. So this sign right here where somebody's grabbing their chest, that's actually called the Levine sign. So I always think of Adam Levine grabbing his tattoos. So that's the Levine sign right there. So more accurately, angina pectoris. There's also Vincent's angina, which is a mouth infection known as trench mouth. So angina pectoris. Death certificate from Vincent's angina. Can't just call it chest pain. Other things cause chest pain. If you have a patient that is saying they have chest pain and you don't know anything about them, or if you're working in a clinic, it's always cardiac until proven otherwise. So a broken rib can cause chest pain, pneumonia can cause chest pain, heartburn can cause chest pain, gallstones, pulled muscle in the chest or the rib area, pulmonary embolism, and a panic attack. So when somebody has pain on the outside of their chest, it's like if you pushed on their chest wall, their muscles, and they were like, ow, ow. That's called condochondritis, and it's not the heart. You cannot reproduce chest pain from the heart on the outside of the body. The temporary chest pain, discomfort because of insufficient blood oxygen supply to the heart, so that it can cause ischemia. Demand exceeds supply, so the heart needs more oxygen than the vessels are giving it. This is a typical distribution of referred pain. And the reason you have pain in your neck is because in embryonic life, the heart is kind of in the neck initially. And this is very typical of men. Women have different symptoms. So they might have this heavy sensation. They might say they feel like they're being crushed, like they have an elephant stepping on their chest. It's radiating left arm or neck. And it's worsened by exertion. And it can be relieved with rest or nitrates. So you always want to ask somebody, did anything happen to cause this pain? What does the pain feel like? How long has it lasted? Where is it rating? What is the quality? What's the sharp, dull, pressure? 0 to 10, what would you give it? You always want to ask those questions. Is angina pectoris the same as heart attack? Absolutely not. We know that nitrates and rest do not relieve a heart attack. Symptoms can be the same. Angina, there's no damage to the heart muscle itself, so the ischemia doesn't really occur. So hopefully we'll talk about the zones. There's 3 different zones when you have a heart attack. In the inner zone, the ischemia is the permanent muscle death. In a heart attack, there is death of some amount of heart muscle. This is a cross-section of the heart. You can see right here, that's the permanent ischemic destroyed tissue. So the heart will build collateral vessels around it, but it will never actually heal that part. No death tissue. MI, angina. So angina can be stable. It's very predictable, usually after exertion, and then goes away. Or it can be unstable. And this occurs at rest. Unpredictable pain can increase for no reason at all. So if somebody is just sitting there and they're having chest pain, that's unstable angina. That's pretty bad. Clinical symptoms of angina. Yeah. Substernal pain, pressure, squeezing, dyspnea, difficulty breathing, nausea, diaphoresis, they're sweating a lot, restlessness, pain eased after taking nitrates. Not true for an MI though. Pain is the main symptom. Pressure in the chest, spreading pain, lightheadedness, sweating, nausea. You'll see these are some different patterns. This back pain is very typical for women to have back pain. The textbook case, pain radiates down the left arm. That's not all the same. Always the same for everybody. So quality. Usually described as tightness, squeezing, crushing. Not typically described as pinpoint or knife-like. And the elephant's sitting on you. The duration. Usually a short time for angina compared to heart attack, where it's going to be longer. And it's relieved by nitro. So rest, nitro. So angina can be relieved with rest and nitro. MI cannot. Other symptoms. Anxious. If you were having an elephant sitting on your chest, I think you would be very anxious, very restless. Might have indigestion, shortness of breath, sense of impending doom. Many people exhibit denial. Can't be me, I exercise. Must be indigestion. Possibly something I eat. And they may delay getting help. This denial is not good. Diagnostics for angina and MI. Laboratory tests of cardiac enzymes, mostly the troponin. That's the one that's very specific to the heart. A resting EKG or a stress EKG, echocardiogram, and coronary angiography or cardiac cath. So this is the level, so the troponin goes up the highest and it lasts longer. Your patient was admitted yesterday with chest pain. Their cardiac enzyme tests come back showing no elevations over 24 hours. They most likely experienced a heart attack, angina attack. Yes. No elevations in the troponin, not a heart attack. This is a normal versus a myocardial infarction on EKG. So here's the baseline. So here's the S, here's the T. So from the S to the T, it's pretty much baseline. But not here. See, so here's the baseline, right? And this is the S to the T, definitely elevated above the baseline. So you can have a STEMI and a non-STEMI. ST segment elevation or non-ST elevation, MI. Treatment for angina, therapeutic measures. Prevention, always number one. Baby aspirin. Why baby aspirin? Statins. Baby aspirin keeps your blood from clotting. Statins lower lipids. Statins end in statin. So like atorvastatin is Lipitor, and rosuvastatin is Crestor, but they end in statin. A word about statins. So here's atorvastatin, Lipitor. That's like the low dose, really, really low dose. It's meant to lower cholesterol. End in statin. Atorvastatin, Lipitor. Lovastatin, Lipitor. Given at night, body makes cholesterol at night. That is 12 midnight to 3 a.m. is when your body is going to reduce your cholesterol the most. Do not take with grapefruit and cloves. Tip: a lot of things interact with grapefruit juice. Just don't take grapefruit juice. Report any muscle pains. Can cause muscle breakdown. Rhabdomyolysis is an emergency. And treatment prevention, Plavix. Make sure you know these very, very common names, the generic and the brand name. When people say, oh, you'll get both on the NCLEX, I had just the generic name for Plavix on NCLEX, but I knew it was something to do with cardiac, and there was only one answer related to cardiac, so I answered it and I got it right. And then I had to go back and look it up because I was like, oh yeah, it's Plavix. So don't assume that you're going to get the generic and the brand name. And I found that NCLEX was like the very common meds. You know, there's just so many, and focus on the classes of meds, and doing the basics and what you would do with them, and then try to memorize some of the common ones in that class. The Plavix, antiplatelet like aspirin, makes platelets less sticky. Kind of like a blood thinner. So treatment, nitrates, nitroglycerin, not the explosive kind. It has a vasodilator effect, so it opens up the vessels. It makes them dilate. They become bigger. And that improves coronary blood flow. That also improves the amount of oxygen that's going to get to the tissues, lowers the blood pressure, different varieties. So there's some that act immediately, sublingual, and there's some that are more time released for prophylaxis. And those are like the pastes. So immediate effect. So there's the tablets, the little tiny tablets, and the spray. Sublingual, it means under the tongue. Do not chew, do not swallow. And then the spray. Note the amber colored bottle. Yeah, these need to be protected from the light, and you need to make sure that they haven't expired. I can't quite see the expiration date on this one. There's 25 tablets in here. They're very, very small. So, take the first pill. 5 minutes, no relief. Take another one. And repeat. Total of 3 tablets. Call 911 if no relief. I would call 911 with the first sign of chest pain, because You don't want to wait that 15 minutes to call 911. Do not drive yourself to the hospital. Taking some sublingual do's and don'ts. Keep an original container. 6-month expiration, keep it fresh. Keep it with you. Tingling sensation in mouth signals that the pills are still good. And as a caregiver or nurse or bystander, don't touch them. Wear gloves. Common side effects: headache, facial flushing, dizziness. So it's lowering their blood pressure. You got to be careful when you're giving nitro to somebody who has very, very low blood pressure. If you know their blood pressure is severely low, you got to be careful with that. So common side effects: the dizziness, the flushing, that's vasodilation. Meds for prophylaxis. So this is going to prevent. This is not the immediate, you're having that pain. This is to prevent it. Beta blockers. Beta blockers end in LOL. So Inderal, propranolol, that's a pretty common one. This one's also really good for like test or situational anxiety, and it's really good for migraines. Calcium channel blockers: Procardia, nifedipine. So these penes, calcium channel blocker, amlodipine, which is Norvasc, those are all calcium channel blockers. Time release. So you have pills, pastes, and patch. Inderal. LOL. Slows the heart rate, reduces blood pressure, and oxygen demand for the heart. So the heart can meet that supply and demand. It's kind of balanced. Oh, you need to know patient's heart rate. If their heart rate's under 60, you're not going to give this med. So there's vasodilators, calcium channel blockers, and the nitrates. And there's also cardiac depressants, which calcium blockers also are, and beta blockers. And then there's some other medications that they may have. Calcium channel blockers, indapine, slows the movement of calcium ions in muscle. This allows blood vessels to relax and dilate. Lowers blood pressure, makes less work for the heart, doesn't have to pump against a higher blood pressure. Kind of gives that heart and blood vessels a little break. Penes, nifedipine. Pine trees are strong. Calcium is strong like bones. Your PowerPoint. Nifedipine or Procardia. So nitrobid paste. This is the measure. Remember we did this in farm. Absorb through the skin. You also might have the nitro patch. Remember to rotate the site of application. Don't continue to use the same skin area. And remember to get rid of the old one. Don't want 4 patches on there. Patches are off for 8 hours per day, so they don't develop tolerance. They give Tylenol to prevent any headache side effect. Wear gloves. You do not want this absorbed into your skin. Nitrates reduce blood pressure, so monitor their blood pressure, especially notable for certain men. Drug interaction alert. Don't mix nitro with Viagra. A little blue pill. Viagra also lowers blood pressure. You will bottom out and pass out. Another anticoagulant. Rabbits, like Coumadin, but not as powerful. Technically, and it's an antiplatelet med. Rabbits. Surgical treatment. Percutaneous coronary angioplasty. Let's stent. It's done through an artery. CABG, or a coronary artery bypass grafting. This is open heart, but this is also doesn't have to be open heart. This can also be through endovascular, so they go through a vessel in your leg. And this is the occlusion. The wiring goes in. This is all like shows up in the X-ray really well. So it has a balloon inside the stent. They blow up the balloon. The stent expands, and then they release the balloon, and the stent stays in. So they need to stay flat. They need to have their head of bed less than 30 degrees. You need to check CMS, circulation, movement, sensation, distal pulses, and assess the site for bleeding. That's very important. Heart-lung bypass. So they can't operate on the heart and the vessels if there's blood flowing through it. It'll just bleed out. So they have to do a bypass. CABG can be done endoscopically. Total endoscopic coronary artery bypass. This is done with the Da Vinci robotic system. Myocardial infarction. Development of dead areas, necrosis. This is the part that's not coming back in the myocardium as a result of oxygen deprivation. Big difference between angina and MI. Angina does not get dead areas. Affected areas recover after angina. So the ST elevation from the baseline. Depth of the tissue, no tissue depth, MI, angina. We saw this already. So dead areas will heal and form a scar. It takes up to 2 months. Scar area does not conduct electricity, so it's a non-viable part of the heart muscle. It does not contract or pump blood. That's hard to achieve 100% efficiency with your heart function after MI. This is the scarring. See. Common complications of MI within a few days. It can go into cardiogenic shock. It can have a dysrhythmia, and they can develop heart failure. Blood pressure drops because there has been significant damage to the heart muscle. Not a good blood pressure here. Not able to pump out adequate blood to create proper pressure. Arrhythmia or dysrhythmia. Dead tissue does not conduct electricity. Not good. No P waves. Anybody know what this one is? That's a scary one. This one can be stable. People live with this. BTAC. BTAC is not good. Complications. Heart failure. If enough heart tissue is damaged, heart's certainly not 100% effective. Leads to backup of blood because heart cannot process the blood fast enough, and heart failure. Can back up to the lungs, causing pulmonary edema, and that's if it's left-sided heart failure. Pulmonary edema. Fluid in the lungs. So symptoms, basically the same for angina. It's not the pain's not relieved though, and there's actual damage to the heart. So, women, leading cause of death. African American women are at highest risk, higher mortality rate, and more complications than men. So if you remember mortality, so that means that more women die from heart attacks than men, and women have more complications. Prodromal symptoms, that prodromal just means anything leading up to it. So sometimes people have prodromal symptoms for an infection or something else. So if you ever see prodromal, that just means like leading up to. So women can have prodromal symptoms a month before the MI. Unusual fatigue, sleep disturbances, dyspnea, and back pain. So, yeah, that's most women. It's hard to say you're having a heart attack. So this delays treatment and less aggressive treatment may be given. So unusual fatigue, sleep disturbances, and shortness of breath. So all of these. So African American women are more at risk for heart disease than any other ethnic group in the United States. Higher incident of diabetes and hypertension, which result in deaths from cardiovascular events, are underrepresented in major research trials, are up to 60% less likely to receive aggressive diagnostic testing. So almost all medical trials until last 10 years or so were always male, white men. So we don't know that much about women, and we don't know that much about different ethnic groups. If you think you are having a heart attack, time is muscle. Just like a stroke, time is brain. A heart attack, time is muscle. Chew one adult 325 milligrams or 4 baby aspirin, which are the 81 milligrams. Call 911. Do not drive self to the hospital. MI. Here at the hospital may be given a thrombolytic in the ER. It's a clot buster, like TPA. TPA is clot buster. Thrombus is a clot. Lytic, lyse, destroys, breaks it up. And then it usually can restore blood flow right away. Oxygen. Oxygen needed to keep O2 sats over 82, and you titrate. So titrate just means you increase as you need to until you get to the therapeutic level. Nasal cannula or mask in the diet. Clear liquids, then small bland meals. You want to be easy on the GI tract and the heart. Low sodium, low fat, low cholesterol, and avoid extreme temperatures. No caffeine, and no salt, no soda. They're going to have very close INOs and daily weights. You want to assess for fluid balance. Telemetry. So having a dysrhythmia after a heart attack is a complication. This is a trigeminal PCV, which is a preventricular contraction, and this is what they look like. So this just means that the ventricles are contracting sooner than they should be. So PVC, preventricular contraction, and it's every third beat. That's why it's called trigeminal. So this one's normal, this one's normal. Third one's not. Analgesics, morphine for pain. Some side effects of morphine: reduced respiratory rate. And you need to check their heart rate and respiratory rate. Anticoagulants, so they may get heparin, they may get Lovenox, which is a low molecular weight heparin, Coumadin, or baby aspirin. Keep the existing clot from getting bigger. They don't dissolve the clot like TPA. TPA is a clot buster. These kind of just keep everything in check. And then you need to check the lab tests often. PT, INR. This is for Coumadin. PTT, 2 H's, 2 T's looks like an H. That's for checking heparin level, therapeutic levels. Coumadin is PT. PTT heparin. The 2 T's look like an H. That's how you remember that. Lasix. Know this medication. This is a really, really common one. Diuretic. All diuretics get rid of fluid. Probably be anti-diuretic to reduce the workload of the heart. Ionos. CAD. Remember what K is? Potassium. The little trick, potassium, if you're giving it intravenously, you want to put it in the largest vessel possible. So don't put it in the hand. The higher up the arm, the bigger the vessel. It can burn through the vein. So you're getting diuretics, and then you have to give them potassium. You have to do this to treat this, to treat this, to treat that. Mona, morphine, oxygen, nitro, aspirin. Heart failure, congestive heart failure, really just heart failure. So the pump does not effectively move blood through the body, through the heart. It slowly gets worse over time. Causes: hypertension, a history of a myocardial infarction, valve issues. Valves either have regurgitation where they don't close all the way, or they have stenosis where they don't open all the way. So blood can't get in, or with regurgitation, it backs up. Chronic obstructive pulmonary disease, emphysema, and emphysema and bronchitis. Obesity, fluid overload, pregnancy. So remember, pregnant women can have an S3 sound that goes away after pregnancy. So it's not a pathological finding in pregnant women. Symptoms. We should review yet again the two sides of the heart and what they do. So the right side of the heart, it gets all of the deoxygenated blood returning from the body and pumps it to the lungs for the gas exchange, picks up the oxygen, drops off the CO2. So all the blood from the body goes into the right side of the heart. The left side of the heart, this gets the blood from the lungs and then it pumps it out to the body. So, early signs: gradual fatigue or exercise intolerance. So if you see people that are like huffing and puffing going up a flight of stairs, they might be like, oh, it's my asthma, but really it's probably heart failure. For starting persons, it's good to break up heart failure symptoms into right and left sided. This is a really nice little diagram. I like this one. Comes in from the body to the right, goes to the heart from the right, goes to the lungs, comes back from the lungs into the left, and then goes out to the body from the left. The heart isn't pumping, blood is backing up to where it came from. So, blood in left side of heart came from where? Nice backup right here. If it's from the left side, it came from the lungs. Left lungs. So that is why there would back up, kind of like a traffic jam. So you can have lung symptoms: pulmonary edema, dyspnea, orthopnea, cough, crackles. Can't palpate this edema, you need to auscultate. Frothy sputum can be pink in heart failure. Nice. left-sided heart failure. So the left side came from the body. So it's going to back up in the body and cause problems in the body. Sorry, this is not right. The left ventricle is not pumping out enough. This may also lead to less blood flow to the kidneys. Okay, so the left side is pumping out blood to the body, and it could have less blood flow. The kidneys are not going to get blood flow. Okay, so you can have impaired kidney function, elevated BUN. I just want to go back. Elevated BUN is not a very specific test for kidney function. It can be altered by poor kidney function, but it can also be elevated with dehydration. So you really want to look at creatinine is the more accurate for kidney function. But both tests are for kidney. Cerebral anoxia. No blood, no oxygen. Remember that heme is carrying all the oxygen, the hemoglobin. So they have fatigue, restlessness, confusion. There's left-sided heart failure. Cough, crackles, wheezes, bloodshot sputum, cyanosis. They lean forward to breathe better. The left-sided heart failure, left comes from the lungs, and it affects the lungs. And the right side back up to the body. So you can have dependent edema, dependent on gravity. So when they have their legs up, they don't really have that edema. In lower extremities, ankles, feet, this is some like 3+, 4+ pinning edema right here. Weight gain from fluid retention. That's why people who have heart failure have to have strict, constant weights. The right-sided failure. Enlarged liver. Hepatomegaly. GI discomfort, anorexia, jugular vein distension, nocturia. You're going to pee a lot at night. Different than enuresis, which is bedwetting. So, nocturia. So, laying down aids venous return from the legs. The leg edema returns to the general circulation. More fluid goes to the kidneys now, and more urine is produced. So, yesterday's edema, tonight's bathroom trip. Pop quiz, short answer. In men, what is another more common reason for nocturia? BPH, benign prostatic hypertrophy. There are some medications that affect blood pressure that can be taken to help relieve this. Right-sided heart failure, fatigue, increased peripheral venous pressure, ascites, enlarged liver and spleen, anorexia, weight gain, dependent edema. Patient symptoms will complain of fatigue, weight gain. Chest x-ray looks for enlarged heart or fluid in the lungs. Check for jugular vein distension. You can actually measure this, and there's an angle, and this tells you how severe it is. EKG. They may have had a silent heart attack. Sometimes people don't know they ever had a heart attack until they have the EKG that shows a previous heart attack. Echo. You can see ejection fraction and look at the valves. BUN, creatinine levels. Kidney function and cardiac output. The BP is related to the PP. If kidneys don't get blood flow, they can't work. Levels rise in kidneys, not filtering properly. So that's why you have those elevated numbers. So quick kidney review. Which kidney? Blood flow in, filters, some goes out, some stays. These little nephrons, that's the important part of the kidney. Glomerulus. So the glomerulus filtration rate, the rate that this is filtering, that's how you really measure kidney function. So they can have a decreased GFR. Thyroid levels, relationship with thyroid and heart. Both hypo and hypothyroid can affect heart function. BNP levels, a test that probably never heard of. So when you have dilated cardiomyopathy, you'll have elevated BNP levels. Hormone produced in response to overstretching of the vesicles. Similar to a diuretic, produced by ventricles of the heart when they are overstretched. We measured in a blood test to diagnose heart failure. So this is, if you listen to the other video, it's like the little drain on a bathtub when the water's getting too full. That's the BNP is elevated and signals the kidneys to get rid of more fluids. Diuretic effect of BNP. Vasodilation. BNP is produced in the ventricles. Aldosterone inhibition and diuresis, renin inhibition. So BNP, so basically if you're greater than 100, that's a diagnosis. BNP sounds like BNP. BNP, heart failure. BNP, basic metabolic panel, that's electrolytes BUN, the basic chemistries. How is it treated? Need to reduce the workload of the heart. Reduce fluid, reduce blood pressure, and let the body rest. Rest, case activities, assisted devices like wheelchairs, adequate sleep, with extra pillows under the head, limit fluids before bedtime. Heart failure leads to fluid retention, so you want to limit foods that make you retain water. Sodium. No snacks. 2.5 grams a day. 1 teaspoon of salt has 2,300 milligrams. Need to avoid high sodium foods. Some offenders here. Salt shaker, obviously, that's pretty obvious. Canned, any canned foods. That's like an collect to know thing. Cheeses, condiments, salt, really? Yeah, of course. High sodium shockers. So some people are put on a salt restriction diet, sodium restriction diet, 2 grams a day. Need to be aware of sodium sources other than salt sugar. Some people will use salt substitute. Salt substitute, get all that potassium. Mrs. Dash. No potassium. Most people with heart failure are on a diuretic like Lasix or hydrochlorothiazide. Most people with heart failure try to restrict sodium. They may use substitutes that are high in potassium. Be careful if using potassium-sparing diuretic. Like aldactone may end up with hyperkalemia, which is elevated potassium. So supplemental oxygen, nasal cannula mask. Need to know baseline pulse oximetry level. Typically like to see the pulse ox at or above 92, and you may need to titrate it. Need to assess fluid loss or gain. Preferred way is weight loss or weight management for daily weights. A pint, a pound, whirled around. A gallon weighs about 8 pounds. Daily weights. Same time every day. First thing before breakfast. You need to make sure you zero the scale and it's calibrated. And it needs to be calibrated yearly. Same clothing. So 2 pounds in a day, 5 pounds in a week. So remember, 8 pounds is from a gallon. So there's 5 pounds in a week. That's over half of a gallon of fluid. So weight gain means fluid retention, excess fluid volume. And they need to increase their treatment. So surgery can be performed if they need to with heart valve replacements. So this is from a pig, this is from a cow, and this is a mechanical heart valve. So it's important to know the treatment and if the patient has mechanical or not. Medicines, diuretics, get rid of fluids, potassium replacements, digoxin, ACE inhibitors. These are the ones that end in pril, like lisinopril. Beta blockers end in LOL. Fancy IV medications. Diuretics, Lasix. Main effect is fluid loss. Diuresis. So these are some common ones. Umethadine, Lasix, which is furosemide, and thiazide diuretics, which the most common one is hydrochlorothiazide. But they tend to make you lose potassium, so you need to monitor those levels. So about 3.5 to 5.5 is the average to know. Your book, different labs are going to have different numbers, but 3.5 to 5.5 is a good round number to remember. Potassium sparing diuretics. Don't lose the potassium, they hold on to it. So if they're on aldactone, gotta be careful. The salt substitutes that have potassium, they'll have too much. Potassium replacements. So abnormalities in potassium, hyperkalemia, elevated potassium, or hypokalemia, low potassium, can cause dysrhythmias. The heart is a sodium potassium pump. So CAD is one brand name. Remember the dietary sources from potassium: orange juice, bananas, potatoes. Run those bananas, but orange juice, potatoes, obviously not the chips. Digoxin. slows and strengthens heart contractions. It increases the cardiac output, so there's more blood flow moving. So you need to check the heart rate before giving it. Apical pulse needs to be at least 60 beats per minute. Why are elderly at risk for drug toxicity? Drug metabolism in the liver. When you're really young and really old, your liver does not metabolize medications as effectively, and that's about age 4 and under, and generally about age 65. So a lot of drugs are metabolized in the liver and excreted in the kidneys. So if you have decreased kidney function or liver function, you're going to have a change in metabolism. So both are less effective as we age. So these medications will build up in our body, so patients can have a bioaccumulation of medications. So they'll have too much medication in their bloodstream at any time, and that can be dangerous. So toxicity. You can have low heart rate and fatigue, anorexia, abdominal pains, nausea, vomiting, visual problems. You can have, and this is not just an elderly, but this is an NCLEX thing to stick in the back of your head somewhere. Digoxin, yellow halos around their eyes from digoxin toxicity. Low potassium levels may be at risk for toxicity. Higher, many take diuretics also. The digoxin has, you're frequently checking those levels. So normal digoxin levels, 0.8 to 2. So lithium, I like this little toxic level. Lithium is 2.0, to digoxin 2.0, and theophylline is 20. So I like that. If it's over 2.0, it's a toxic level. ACE inhibitors, one of my favorite meds. They just do so much. Angiotensin converting enzyme inhibitor. That's what ACE inhibitors do. They inhibit this conversion. And these end in prils, like April ACE inhibitors, prils. Main effect is to decrease blood pressure, makes it easier for the heart to pump out blood. By decreasing blood pressure, easier for heart to pump blood out to the body, clear it out. Less crowded, less pressure getting in and out. ACE inhibitors are also help protect kidney function. So they're really good for people with diabetes, even if they don't have hypertension. So lisinopril or zestril, capitril, pril. Lower blood pressure, dizziness, don't get up too quickly. Beta blockers cause the most hypotension. You're at a higher risk for having orthostatic hypotension, dizziness from a beta blocker than the other cardiac meds, but you still have to be careful with them. But extra careful with beta blockers. So orthostatic hypotension, if you measure somebody's blood pressure supine, sitting, standing, and there's a change over the 10, and then that's orthostatic hypertension. But if it's change of like 137 to 132, that's not orthostatic hypertension. A side effect unique to ACE inhibitors is a dry, hacking, persistent cough, ACE cough. So if the cough is troublesome, you're going to switch meds. They will cough all day long, and it's really annoying. Generally, this happens within the first 2 weeks of starting this medication, but it can occur later, but generally it's within the first 2 weeks. And you'd usually switch to a different medication. One that's the most comparable would be an ARB, and those are the ones that are sartans, like those sartan. Don't need to try cough. No cough medicine. Beta blockers. LOLs slow the heart rate. They prevent adrenaline, which is also epinephrine, from stimulating beta receptors in the heart. Epinephrine and norepinephrine affect blood pressure and heart rate. Decrease blood pressure and decreases heart rate. Metoprolol, low pressor. LOL. Propranolol, Inderal, LOL. Atenolol, LOL. So, dizziness, lightheaded, fatigue, bradycardia. Need to be aware of heart rate, just like digoxin. You don't give a beta blocker unless you know their heart rate. It can cause impotence. It's a side effect from beta blockers. Never stop a beta blocker quickly. You're more likely to have orthostatic hypotension with beta blockers. The biggest time you're going to have a change is when you start a beta blocker or if you change a dose. Fancy IV medications. This is an acute setting. BMP. We already know about BMP. So it can be made in a lab and given IV. Dopamine. A neurotransmitter, affects heart rate and blood pressure. Usually dopamine is given as a med to increase blood pressure or shock. So dopamine is usually on a crash cart. This is a medication that you'll see on a crash cart. Given at a low dose in heart failure because it improves blood flow to the kidneys, therefore has a diuretic effect. That's all, folks. All right, thank you. Look for the respiratory slides to come.